Hello. Today we are talking about the tachyarrhythmias, bradyarrhythmias. In general, the arrhythmias, we have the bradyarrhythmias that are mostly sinus bradycardia, first degree atrioventricular block, and second degree atrioventricular block like Mobitz 1 or Wickenbeck, and the second atrioventricular degree Mobitz 2. We have the third degree atrioventricular complet, the sixth sinus syndrome with bradycardia tachycardia, and the supraventricular arrhythmia like sinus tachycardia, atrial fibrillation, atrial flutter, and the MAT, and atrioventricular reentry, nodal reentry tachycardia, and atrioventricular reciprocating tachycardia, and the paroxysmal atrial tachycardia. The ventricular tachyarrhythmias are PVC, ventricular tachycardia, ventricular fibrillation, and bursitis day points. What about if we wanted to speak about the sinus bradycardia, mostly in hypothyroidism, we have to see that the patient presents with syncope, lightheadedness, or like hypotension, and we have to give atropine, and sometimes are from beta blockers or calcium antagonists. The first degree, we can say atrioventricular block is when the PR interval in EKG is more than 200 milliseconds, and we don't do nothing in this case. What about the second degree? Mobitz 1 is for increased vagal tone, mostly in coronary ischemia or infarction, and the drug effects of beta blockers and the calcium antagonists. Usually is asymptomatic. We have a progressive PR lengthening until dropped QRS complex. So we give atropine here. And Mobitz 2, it's in generally from the disease like fibrotic disease mostly, and we have the progression to the third degree atrioventricular block, unexpected drop beats without a change in PR interval. So we have to give a pacemaker placement here. So the third degree atrioventricular block is more with syncope, dizziness, acute heart failure, hypotension, and canyon A. So no relationship here between the P waves and QRS complex and the pacemaker placement. Sixth sinus syndrome, it's mostly tachycardia, bradycardia with secondary tachycardia or bradycardia with dyspnea, chest pain, TIA, and stroke. The most common indication for pacemaker. What about the supraventricular tachyarrhythmia? Sinus, we say tachycardia here, hyperthyroidism, shortness of breath, palpitations with ventricular rate of sinus rhythm more than 100 here. Treat the underlying cause mostly. What about the atrial fibrillation? We have to say the pulmonary disease, ischemic, rheumatic disease, anemia, atrial myxoma, thyrotoxicosis, ethanol, sepsis, hypertension, congestive heart failure. With this, patient has irregular pulse and no P waves here with irregular QRS response. And what about we have to do the chart score 2 with anticoagulation more than equal or more than 2. We have to give warfarin here. And the atrial flutter, we have the sawtooth waves in the EKG, and the patient with palpitation, syncope, or lightheadedness. Anticoagulation we give mostly here, and cardioversion. Multifocal atrial tachycardia. We had 3 different morphologies of P waves here, and the heart rate is more than 100 beats per minute. We have to give verapamil and beta blockers here. What about the atrioventricular nodal reentry tachycardia? This is with palpitation, shortness of breath, angina, syncope, lightheadedness. The rate is 150 with 200 beats of minutes, and the P wave is only buried, so no P wave here. We have to do the carotid massage here, and Valsava with adenosine cannot stop the arrhythmia here. So the atrioventricular reciprocating tachycardia is mostly with delta with wet Parkinson-White syndrome, and we do same as with adenosine valve carotid massage. And paroxysmal atrial tachycardia we do with the patient has palpitation, syncope, lightheadedness, shortness of breath, angina, more than 100, and adenosine is given here. What about the ventricular tachyarrhythmia or PVC? These are, if symptomatics, we give beta blockers or antiarrhythmics. So we have to look about electrolytes abnormality and hyperthyroidism. What about the ventricular tachycardia? We have to see coronary artery disease, myocardial infarction, heart disease. And cardioversion with antiarrhythmic, lidocaine, procainamide, and amiodarone. What about the ventricular fibrillation associated with CAD and cardiac arrest and syncope, absence of like blood pressure and no pulse here. So electric cardioversion mostly, and Torsades de points, we have to correct the hypokalemia, we give magnesium sulfate, and there are polymorphic QRS and palpitations, dizziness, and syncope. And that's it. Have a nice time with wow heart and healthy heart. Bye.